Hello, welcome to our program. I'm Dr. Lewis Hassel, Professor of Pathology at the University of Oklahoma Health Sciences Center, and our program is part of the Digital Anatomic Pathology Academy, a joint venture with Path Presenter and the Digital Pathology Association, which does offer complimentary membership to trainees and to those from developing countries. Our program today is not a particularly challenging case, but an interesting presentation and set of circumstances surrounding an otherwise very common issue. So the patient is a fairly young woman who has at present at least two vulvar masses and previously has a history of a perianal mass and a vaginal mass that have been sampled over the years. So this presents sort of an interesting consideration of what sort of thing causes multiple recurrent lesions in the vulva. And of course, most commonly, we would think about condylomata, cutaneous-derived lesions. Certainly, patients with endometriosis can have recurring problems over time, as well as the number of cystic lesions that can present in this location, the Bartholin's gland cyst, the Skene's gland cyst, and so forth. Patients with neurofibromas may also have multiple masses and may develop recurrent masses if any happen to be excised. Nevi, relatively uncommon. Smooth muscle lesions likewise can present in the vulva, but usually not as multiple and recurrent lesions. And then we have that wide array of mammary-related lesions, as the vulva does sit very prominently within the milk line and can present with those kinds of lesions as well. So these lesions were excised. Actually, this particular sample was thought to be a cyst, and attempt was made at draining it. So you can see we have cutaneous surface here, and then the surface is somewhat eroded and granulated. So it almost looks like sort of a pyogenic granuloma at low magnification with an ulcerated surface and so forth. But then we very quickly recognize that these are not vascular structures, but rather a mixture of small ductal structures, a canaliculi, and an associated loose fibromyxoid stroma. So this very much looks like a fibroadenoma, as they discovered when they attempted to drain this cyst and found that it was mostly solid. So the lesion on the opposite side was also excised, and you can see here this also has a very nice leaf-like pattern, sort of almost phylloides type of lesions with very broad open spaces, and this very benign appearing ductal type tissue, glandular tissue within the fibrous stroma. No apocrine metaplasia or other features were identified, but you have a few areas where it looks like you may have a little bit of sort of myoepithelial differentiation, maybe even some almost ciliated type cells in some of these areas as well. Well, as we looked at this patient's history, we discovered that indeed he had previously had at least two and possibly a third similar lesion excised from the vulvar or perianal area over the preceding several years. When we think of mammary-like vulvar tumors, the most frequently encountered here in this location is not the fibroadenoma, but rather the hidradenoma papilliferum. Fibroadenoma and phylloides tumors, however, do occur in this location, as do some of the breast epithelial cancers. Predominantly ductal, relatively rarely lobular, and of course Paget's disease, which we've talked about in other videos. We also did one recently on myofibroblastoma, which can also have a vulvar variant that can occur exactly identical to the mammary type. Fibroadenomas are the most common tumor of the breast, accounting for probably 40 or 50% of breast biopsies, but they're much less common in extramammary sites. Usually these tumors are solitary, but they can be multiple and multi-site. In fact, these tumors have been found in some circumstances, up to 15% of cases, to have a familial multiple sort of setting circumstance, and there may be some relationship to family history in that regard. Our particular patient was rather obese, but usually obesity is considered a negative risk factor for fibroadenoma. Of course, the morphology is not particularly challenging. We have this classic biphasic appearance, but there can be varying degrees of epithelial hyperplasias, maybe apocrine metaplasia. There can be varying appearances to the stroma, ranging from very myxoid to very fibrotic and hyalinized. Of late, MED12 exon 2 driver mutations have been detected in most of these, though this mutation is also found in phylloides tumors. And should immunohistochemistry ever be required, we would find that the stroma is often CD34 positive, that both epithelium and stroma are hormone receptor positive, and that there is expression of beta-catenin and cytokeratin. To date, I have not yet had to apply immunohistochemistry to one of these lesions, but I imagine that there may be circumstances yet ahead on the road. So our final sign-out diagnosis for this case is fibroadenoma of mammary type, multi-site, and apparently recurrent, or at least recurrent over time in this patient. Well, we hope that you enjoyed that fascinating little case, not a challenging diagnosis, but certainly an unusual presentation and clinical setting to discover this tumor. We hope that if you like that, you'll hit the subscribe button and share that with your friends as well, also so that you can catch our future releases on our program. We're very grateful for your support and appreciate the chance to share these interesting cases with you. So until next time, thanks so much for joining me.